Welcome to the Healthcare Nation podcast. I'm your host, Rick Gannotta, and we're committed to bringing you thought leaders in the field to discuss what's new and noteworthy in the health sector. This is the Healthcare Nation podcast. Welcome to the Healthcare Nation podcast. I'm your host, Rick Gannotta, and Joe and I are here in the studio. Joe, what's happening on your side of the controls over there?
Well, today I thought the guest was very interesting in the sense that we've been talking a lot about like what ChatGPT and language modeling systems could look like, but he actually made some predictions and timelines and like, hey, this is if it was built right, it could do this, which I thought was very fascinating.
Yeah, I'll tell you, this segment dedicated to digital health, right? Which encompasses ChatGPT, AI, ML, even more, wherever you can blue sky it. And our guest, Dr. David Butler, he is really an expert in that, having been consulting for years. And I thought one of the things he did and was bold enough to do, Joe, was put some predictions out there.
Yeah.
You know, making it real for us, which we don't usually see. I think we could look at the literature, look at the data. We know where things are going, but he really was I think confident enough to hammer the nail right in on some dates, including some that were in the near term. What'd you think of that?
I found it to be fascinating.
A little bit about our guest in detail. So Dr. David Butler, again, a physician. Dave is double boarded in internal medicine and pediatrics. That background gives him a tremendous perspective in his area of expertise, which is really the implementation of all things digital, specifically electronic health records across the country, working with health systems. And I worked with Dave myself in the past. In addition to that, he uses lean methodologies to solve organizational challenges, which is fairly novel in the tech space. He has been a recipient of Epic Systems Physician of the Year Award. He's featured speaker at many, many conferences and keynotes around the country. And I think his insights, as I said, perspectives and predictions were pretty insightful. So with that, let's welcome our guest, Dr. David Butler. Dave, my friend, it's been a while. Great to see you. Tell us, what have you been up to? What are you doing with Calyx Health Partners?
Yeah, we've been pretty busy right now. We're trying to figure out, the pandemic and everything the last 2 or 3 years, the cards have been shuffled and thrown up in the air. So we're now just trying to figure out where is this thing landing like everyone else, And this week I'm at Epic for their annual XGM, which is and also their Physician Advisory Council, where doctors come from all over the U.S. to kind of share ideas and things like that. So it's a users group meeting. And that's where my area of expertise is. So that's what we've been up to, just scouting out the environment to see where are the opportunities, who needs help, how can we assist, things like that. And so, yeah, it's interesting.
Listen, Dave, what has always impressed me about you is you're an evangelist, an advocate for digitizing healthcare across the board. Obviously, we worked together in our past on that. But bring me up to speed, particularly with respect to what you're doing right now. What and how do you see the current technological advancements helping systems to overcome the challenges? And, we've spoke before, what's the next step up? I mean, is there a lot to look forward to? I mean, we could go down the road of ChatGPT, et cetera, but I really want to get your take on it.
Yeah, no, Rick, and that's a great question first is, I think the top 5 things or 3 or 4 things that right now is challenging in the healthcare delivery on the delivery side is staffing, right? The high cost, okay? Health equity, okay? And the pitfalls and the promise of some of the new technologies that's being just dumped right now. I like to use that word dump for visual, right? A lot of tech has just been dumped all over the U.S. and sprinkled all over the U.S. and the world over the past 10 years. And now we're all trying to make sense of it, right? And there's so many permutations that we have to do. For example, the EHRs, that's my area of expertise. We spent the last 15, 20 years trying to get them turned on, get the docs off paper, trying to destroy the fax, which is, I heard it was funny. I heard it said the fax is like the digital cockroach, meaning when everything else on earth is gone, the fax will still be here.
Yeah.
And so the goal is, you and I, we're from the fax and paper world, right? And now we're in this
yeah.
pixel. And so the question is like, how do we continue to make sense of it? How do we make sure that we pace technology so that our frontline docs and nurses that are toasty right now from the pandemic, how do we make sure that things that we add now are value add, frictionless, and can immediately help with some of the the burnout and give the physicians back some time and give the nurses some time, right? And even the front staff and the back office, all these things, and hospital. And so those are the things right now that I think that's going to just have to work now.
By the way, I remember many a after shift time being taken up just paper charting. So I can relate to where you're coming from. And obviously I shared history with that, but also being optimistic about the future. And there were some things you talked about clearly in that workflow, burnout, the equity issue. I want to touch on all of those.
Definitely.
But let me just get to one thing specifically. I would say this. You have extensive experience specifically in Epic systems and their clinical suite and their related applications. With respect to that platform, and if you could speak to it, what do you envision the next breakthrough will be with EHR technology? Will it be the AI ML part? Will it be something that impacts and assists and enables, new models of care? What's your perspective on that, Dave?
Just yesterday, Epic kicks off their whole physician advisory council. So hundreds of docs all over the US comes here and we take a look to see what's coming next. What is Epic working on? Where's the roadmap? And typically your EHR companies like the Cerners, the Epics, Athenas, and all those, they're very good at watching where the road is going and making sure their software meets those regulatory requirements, usability requirements, and integrating some core innovative technology in their software. So Epic this week, that was a question that came up. And so the biggest talk here is AI, large language models, ChatGPT, GPT 3.54, all that. And you can go. And by the way, just for on this thing, can someone tell OpenAI to rename ChatGPT? I think they got to get some branding on that because it's just, okay, next, that's a side note. So
No, yeah.
streamlining it.
A lot of folks looking up generative, I think it's pre-work. It's interesting, but
Yes, I've always been an advocate and proponent for technologists, analysts, IT folks, but at my core, I'm a physician. At my core, I like to use technology as seamless, right? And so it's interesting. So you see some of the techie stuff that gets released into the wild, and we can feel like, oh, this got tech written all over it. It feels techie. And so I think the win is going to be to continue to refine these products as they come out to make them have a better UX or user experience, right? And that was the biggest challenge. I can't tell you how many times, I think you and I even worked together because physicians were like so upset, like, we bought Epic, it's supposed to be this and that, but, because of it is so complicated when you're dealing with humans and I call it 256 shades of gray of the human, and you have ones and zeros, these computers that try to make that work, right? And so I think now we're at a place after 15, 20 years of getting this EHR stuff in, now we're at a place like, okay, let's make it home. The physicians are burned out. They spend a lot of time in the EHR, in basket messages, patients back and forth, a lot of time in the evening. So many people don't understand that is zero compensated work, zero.
Right. Yep.
And so back in the day, patients come in, I see them, take care of them. They go home and they would call if there was questions. I could look over triage and call them back and go from there. Now with the ease of messaging, it's great for patients, and I'm a big patient advocate, but we have to really address the burdens that we're putting on the healthcare system that were not even thought of pre-pandemic, as far as the increased access, digital access, the increased messaging that's coming across, and the convenience of care now that digital provides. So now I think we're running into a peopleware problem, not a software problem.
Yeah, along those lines. And I think getting back to the burnout and even the workflow piece, when you think about the application, and let's just say the promise of ChatGPT and the AI side, just to call that out specifically, when will it be actionable? When do we know that, well, we're satisfied with respect to maybe some bias within it, that it's been mitigated, or the deployment is going to be in a way that augments and assists versus does the command and control? From your vantage point, what's the time frame on that?
It used to be years. Now I think it's months. And when I say that, I wish I was joking. Like a month ago, Microsoft released a video on YouTube, and your audience can, I'll send you a link and you can put it below the podcast, but basically it was there. When Microsoft wrote a $10 billion check to OpenAI, I think in December last year, whatever, that now empowered Microsoft now to really ratchet up their productivity suite of applications such as Outlook, Teams, right? PowerPoint, their PDF, Bing, Rick, I'm going to say this, right? All my friends and I, we make fun of Bing as it used to be the engine that was just trying its best,
Right.
right? And I think now you're going to see in the next 2 to 3 months, Bing is going to really make a play and Microsoft's going to make a play. Well, they made a play and they're going to start infusing its AI, sprinkling its AI throughout their products in the right place, in the right workflow. And that's going to be the win. So now put that in the healthcare. Epic, same thing. So Epic has Epic Ambulatory suite of care tools. They have a scheduling tool. They have a MyChart tool, right? Now imagine if you can sprinkle a little bit of smartness between there, right? Yesterday, the Epic has demoed this at HIMSS and various other places where the in-basket has been a big challenge for physicians and nurses, especially post-pandemic, during the pandemic, and now there may be some relief with its AI. And that's what we're looking for. We need wins that's going to happen Monday, right? Not in a year, because we have staffing shortages, physician burnout, nurses hard finding good nurses, MAs, and those type of folks are having to work a little bit higher of their licensure. And so what this AI can do, if anybody's played around with the chat GPT and things like that, well, it's no longer just a blank box you ask questions. No, now it's integrated. So as you send a message into your doctor, it'll grab a little bit of it safely, right? And that's the thing. We'll talk about that later. Patient safety, not patient safety, privacy, data protection, things like that. We can talk about that. But it grabs it. It will then just look over it and say, oh, this is a refill request. How about I look through the chart really quick and prep the physician and nurse that receives it so they don't have to do that
Or
work.
cues, right? Cues and prompts, using that impacting workflow.
Absolutely.
All
And
right,
so
we
that's what we're
got some predictions on the Healthcare Nation from Dr. Butler. We like that, Dave.
Oh, it's going to get more before this podcast is over. I got some more.
Yeah.
And not even more, but like, Rick, think about it, man. I mean, all these Epic, I can only speak for Epic, but EHR in general. Think of all the data, right? You've implemented Epic, used Epic, you've been that guy, right? So think about all that data, that clicks and flow sheets and care plans and all the data that's been in Epic about a patient. That was very difficult to figure out how to tie all that together to get some insights or even innovative care decisions or clinical decision support from that. Now it's going to be a lot easier, right? And so what that means is we're going to be able to find insights and see things rapidly that we will never have thought about or had the bandwidth to connect due to all the data, right? So I think those are going to be exciting things. And I think if we use it right, we can actually decrease healthcare costs, right? Improve quality of care, decrease clinician burnout and burden, right? If done the correct way.
So tell me, what is the correct way when you say if done the correct? Because I think that's a loaded question there.
I love it. No, that's a great question.
Ways to do it, and then I want to talk a little about the safety side, and then get into the equity. But if done in the right way, because there's so many. First of all, look, we've got lots of delivery systems out there from a hospital side. You've got pushing 5,000 hospitals. What's the right way?
Beautiful question. I'll tell you the right way. The right way is to, when any sort of technology is layered over top of processes, right? We must make sure that what happens is that we magnify those areas of excellence and we mitigate those areas of unintended consequences. So, and what I mean is when the EHR goes live or when things like that, what happens a lot of times is COOs, CFOs, different C-suites in healthcare delivery will rely solely on the technology to solve everything. And they sometimes will forget, and this is 15 years and 4 large health systems internal and over 20 clients that I've helped, from a C-suite perspective. I find that the COOs and CEOs and those type, they go to the easy win and say, hey, just make Epic do this, make it a hard stop, do this. And what they're doing is atrophying their operating skills, right? And so in order to do it right, that was a question, you have to have operations in the room. We got to have the Rick Gannottas in the room, right? The operations folks that understand healthcare operation in the room. You must have the technologists in the room. And the third leg of that stool, you have to have the doctors or clinicians in the room. So when you get that three-legged stool, you will not make many errors and you'll be able to do it right. Because I found so often that if I just had operations in the room making decisions, they gotta focus their decision on the financial health of the healthcare system usually. Okay. Now, if I had ops and clinicians in the room only, typical
Different calculus.
clinicians.
Yeah.
Yeah. Right. And now imagine, I think what has happened though, a lot of times is when you don't have the doctors in the room, solutions look really easy. If you get the operations folks and the IT folks, they can come up with really cool things, but that may not fit the workflow or may not fit the culture or may not have the change management needed if you had docs or nurses in the room that really, you know what I'm saying? So I say to do it right, you got to have clinical ops and technology in the room with the asterisk next to the culture of the company and some serious change management. But it's hard to put all around those, isn't it?
Yeah. And correct me if I'm wrong. I'm thinking, look, number one, it's an immense undertaking just to implement, let's just say, a new EHR. If
Absolutely.
you're adding new features, right? New
Mhm.
components, you're now going to leverage something like advanced AI and machine learning, all of what we hope will be a promise in the future. It's another leap. And you said it earlier, this step up. We've got to be prepared for that because is it going to have, as you said, the unintended consequences on workflow and
Absolutely.
culture, et cetera? You don't want it to do that. And what always gets me is this going to give us more time at the bedside? Is it going to liberate, the time behind the screen and translate that so that I could be with a patient? I think that's a key point out there because
Mhm.
you don't want to have technology push us obviously in the other direction.
Absolutely. Yeah. So that was a great example. So I think in categories, right? So right now, the top, think of for a physician, the typical workflow in a day, whether in the hospital, whether they're outpatient, wherever they are, right? They cannot do anything significant, meaningful without logging into this screen, right? And when they log into that screen, the tools, their digital black bag is what I call that screen. That digital black bag had better have the things they need right there within reach to do their job. And what we find over and over is that is not the case, right? And so what we're hoping is that this AI now, some of these AI tools, not even just AI, a good, real good report, okay? Just
Yeah.
plain old data.
Yeah.
Can
Dave, what's in the digital black bag?
The digital black bag is analogous to back in the day, think of the Norman Rockwell paintings. The doc would go out to the house, and all those,
Sure.
Americana, right? Back in the day, right? And I think about it like the bag. When they go to those people's home and they open up the bag, you've seen the movies, right? What's in that bag? Well, these docs at the time, they had to make sure that when they got there, they were going to make sure what was in that bag was appropriate for the care that they were going to visit this patient for, right? So if you're a cardiologist, what's in your digital black bag? If you're an ortho, what's in your black bag? If you're everyone's black bag should be a bit more nuanced and bespoke to their field, right? And so that's when I say digital black bag is when when a patient goes to the doctor and they log in that computer, that the tool that they need needs to be frictionless in their face, and the computer needs to act like a computer so the doctor can act like a doctor. Okay. And so long, the computer has just been a blinking cursor, and we've been so frustrated at it. I mean, like you log in and you say, okay, this patient's diabetic. I've seen them multiple times. And then when they come in and I log in, the computer's just like, oh, okay, what's up? We're like, you should have prepped. You know this patient better than I do, that you've seen them 6 times as well, computer. And for you not to bring pertinent information directly to me so that we can start this conversation with the patient, something's wrong with the computer.
Yeah. So let me feed that back to you. So you're thinking like the generative component, the programming component would tee up the patient for you. And if you were a cardiologist, you're going to have a particular emphasis on the cardiac profile, ejection fraction, EKG, whatever's pertinent to you from a diagnostic or whatever testing results you're waiting for to make a diagnosis.
Absolutely. That is a must now. And
So
right now we've been trying to do it. Go ahead, I'm sorry.
I want to put you down on the prediction. So we were talking about it earlier.
Yeah.
You get some how far off are we from that? Because you work with a lot of folks out there.
We're probably about 2 months away from that. Now, when I say that, I mean, it's happening now in certain labs and all those other things right now, but I don't care about it. I'm an applied clinical informaticist. So what that means, Rick, is I know a lot of cool research is going on in the background, large language model, data scientists, PhDs, publishing papers in Nature, Science, and all that. Okay, that's great. I want to grab some of that. We're going to say, how can we get this at the bedside by Monday? That's where I focus, right? And so what I've seen all the research. I'm looking over at the large language models, generative AI, what OpenAI is doing, what Stanford's doing with Llama and some of these other really unique models where they're training it, right, to make sure that healthcare focus. And then once you do that, now you can put that behind your firewall where you now have a large language model like a ChatGPT that's working right here. Right now, there's some guys on the internet using a Raspberry Pi, a little bitty computer. They have figured out a 6 GB download. They now have almost a quasi ChatGPT personal. And so if that's coming for your home personal computer, right? If you could download an app and all of a sudden it scours over your digital files and right. And now what you do, you can talk to it as almost a sentient being. Say, hey, what was the guy's name I met at UCI back in the day? He was a CEO. It's going to say, oh, that was Rick Gannotta. Here's some other files for you. Therein lies the Jarvis. That's where we're going. And it's there today, but it hadn't been integrated fully in the workflows. And so take that to healthcare. You put that large language model inside of an Epic instance, behind great firewall security and things like that so that the data is protected. And where when the patient shows up, now Epic will, or I'm going to say Epic because that's just my area of expertise. I'm sorry, I'm not doing this EHR stuff anymore. And Epic will now, and it's not a sell Epic because you're not buying Epic based on what I'm saying. You either have Epic or you don't, and good luck, So I'm just saying this is that I know Epic and I know the software, so you can extrapolate other places. But I find that when a patient comes in now with diabetes, the same patient, Epic's going to now present, or it should, because that's what the roadmap they're showing here this week, honestly, is how that's going to look. And so when I say 2 months, Epic may have it in 2 months, but the dissemination of it across the U.S., sending it down to your client, your hospital, let the CISOs look at it, let your compliance risk legal teams look at it. That is going to be your challenges. It's typically not the tech, but it's going to be the culture and the risk that new technology brings that's going to slow things down, right? And so back to that patient. When the patient comes in with diabetes now, right, what's going to happen is they're like, hey, this patient, last time you saw him was this, his hemoglobin A1C was this, you prescribed this at the last visit, you reminded them to do this and that, da, da, da. It's going to be now, that's it. That's your summary. Now that saved me 5 minutes of chart review. That's what we call it. Before we walk to see a patient, we look over the chart, right? We remind ourselves, like we even make notes for ourselves. Patient has a dog named Charlie, right? Patient's husband died 4 years ago. Those are things that help us become more empathetic and bring that bedside care back. So I'm hoping, and I feel like if used correctly, that's what this can do. It can bring back the empathy.
Right. This is the enabling component of it. In fact, Joe, our producer, and I were talking about this last week. This is where it really is augmenting your ability so you can spend more time at the bedside, ease you up, compresses the workflow, and that velocity of care, if I could characterize it that way,
That's right.
it gets much faster, but much more focused. And it's not in any way taking away from time with the patient. It's taking away unnecessary tasks that hopefully you're leveraging technology for. Listen, Dave, this is an important component. I want to switch gears a little bit because you talked a bit about this, certainly in our past, and you open up the show with this digital health equity. Certainly it's an important aspect, just ensuring that everyone, right? Particularly, and we're talking about patients here, but everyone has access to quality of care and making sure that there's no digital divide in this. How have you seen, or what's the best that's out there? What's your advice on healthcare systems leveraging technology to reduce disparities and really to promote equity? I mean, this is obviously something that's been talked about a lot. I'd love to hear your points on that and what you've seen.
The things that we're doing now with AI, generative models and things like that, what we know is that first I'll say, there is bias that's built in the models because the world has been biased. So if we build a model based on the world, meaning if you look over the internet, let's say if you're super smart and you looked over the internet and someone asks you a question about this or that, you only have the internet to pull from. And the real question is, where did the data on the internet come from? Right? Humans. Okay? Humans have biases, right? Small example of this is I've been playing around with some of the generative AI imaging creation, right? Where you say, beautiful field or this or that. Show happy people, show me angels. And it'll create this beautiful picture of angels and things like that. It's fascinating, Rick. I don't know if you had a chance to do it, but here's a small example that I've seen over the 6 weeks of just toying around, playing around with. This is my anecdotal. I could say like, show me photos of angels. It'll show these beautiful white angels, right? White.
Right. Yeah.
Okay. I don't know the color of angel, right? But I don't know. Okay. There you go. And so, or like you should picture Jesus in the Last Supper taking a selfie. It was really cool, but Jesus had a lot of white features, right? But that's okay. Because it's pulling from the world that it sees out here and say, oh, there you go. You must mean this, right? So,
I think a reflection of art, culture, whatever it's extracting the data point from. And
yeah,
in
yeah,
medicine, there's always been a level of it, of even with testing, which I know
yep,
was a
there you go.
position.
You get it. I think your company would, I think they were, like, was it, I forget the company where during the pandemic we noticed pulse oxes where the skin pigment of pulse ox wasn't reading right with African Americans. We also know like EGFR, estimated glomerular filtration rate. It's a bit different with African Americans than, others. So when you measure kidney function, right? So these biases just there. And so what these AI models do, they can magnify those biases as they're the truth. And we can say, oh, that's a hallucination or whatever. Is it? I don't know. And so that's what I think is when it comes to equity. So first we have to make sure that we focus on these large language model to make sure we put cartwheels or whatever the words they call them inside there so that can help level the playing field when it comes to the equity part, anything related to race, uh, financial status, any of the social determinants of health, things like that. We got to make sure we test the heck out of that and make sure we try to remove the biases. But even that, for example, also, Rick, there had been probably since the past 7 or 8 years, there's EHR companies and scheduling companies have built algorithms into their no-shows where like if the patient, they can predict if the patient's going to no-show, right? Or they can present to the doctor, hey, this patient is no-show 75% of the time. And what do you want to do with that? Well, typically that's a risk. So we'll sometimes double book in that spot, right? Whatever,
Yeah.
it's just so
Yeah.
we'll make sure. Well,
Over.
the problem with that is nobody asks why are they no-showing.
Right.
And so we could be inadvertently, causing more inequity but now I just saw a study. A company did this. They looked at, I forget what, I posted on LinkedIn, but it was really slick. They addressed it because they realized now what they do, they look on the backside and say, what type of patients are doing this? And if they're minorities or underprivileged folks or historically underrepresented folks like that, then they'll just make sure they're giving 2 extra phone calls 2 days before. And they've shown an increase already in no-show. Patients not no-showing just with that little bit of intervention that costs 0. So,
I also think if you focused also on the social determinants, right?
mhm,
And thought more along the lines, and this is at least for me, one area where I hope is being explored. If you're worried about someone making a decision on whether they can afford their medication or food, it would be good to understand their financial profile. If there was a way that you could leverage technology in a publicly reported, publicly available way to get
mhm,
that information that would prompt the clinician to say, look, let's talk about your medication compliance and
yeah,
whether you can afford it or not,
mhm,
or if they live in a food desert. I think
exactly.
that would give you even an opportunity to complete a picture of someone's clinical profile that we don't have today. And I don't think what I'm talking about is so revolutionary. I think it's out there, but what I see the hope is that this is not going into some HIPAA area. You could probably acquire this information through what's publicly available out
Mhm,
as well.
absolutely. No,
Yeah.
no, you're right, you're spot on, right? So just combing the internet, I mean, there's Experian and RSA, some of those companies that do the that prompt you to say, "Was this your address and this and this? Was this" the information's there, right? So now using that in a unique way to say, "Oh, they never owned the car. Oh, they didn't never own the home. Oh, it's a couple of things that are well studied to say, this is a patient that probably will need extra help." Okay? Outside of race even. They said zip code is still probably more important to know when you're gonna die than your genetic code.
Yeah, studies show it. Absolutely. Zip code
And,
connects. There's no doubt.
and
Yeah. Just a couple more things for you. One, what advice would you give healthcare organizations hospitals looking to improve their use of technology. Let's just talk right now about a couple things. One would be with respect to workflows or new model of care, and also to enhance, clinical outcomes and reduce burnout. There's a lot in there.
I've seen a trend over the past 5, 10 years, Rick. You've probably seen it as well. Executives, CEOs, 3 to 4, 5 years, tenure now, COO, C-suite tenure is getting a lot shorter, right?
Yeah.
And what I found is that just 10 years ago, a lot of large part of folks' job was to determine what technology platform that this institution is going to use to move toward the future, right? And healthcare is digital. It's all digital now. So we now have to think about this. So what I've seen is that executives, COOs, and I use the COOs, CFOs, and CIOs even sometimes, and the CEOs, they don't quite understand the tech stack because they don't know the tools they have. And it's equivalent if all of a sudden you're going on vacation and you load up a Fire Stick with all the cool things you and your family want to watch out in the woods. I don't know, I'm making this up, right? But then you don't know how to use the stick, you know? You got all the cool stuff there, but you're not sure what's on it. You're not sure the passwords, all that, right? So you end up paying more for other stuff. So I find that I find a lot of healthcare executives keep buying software or having vendors come and present, adding Me Too software, because they have a very little understanding of what they own already. I mean, if you own Cerner, that was a big investment. So before you say, hey, can I get a third party to do this or that? And this is only, once again, this is advice to healthcare delivery systems that I'm an expert at, right? And this is to help decrease costs, decrease variation in care, right? Because many times the technology that you have or that you keep dumping into your own healthcare system is causing clinical variation. It's causing you to need more and more employees to manage this stuff. So I would say take a real strong look at your tech stack, check with your CIO and have them give an analysis of what do we own and what does each one of those do? And are they duplicates, right? Because I've just run into so many companies and healthcare companies that are a bit strapped financially, but what they don't realize they're paying for are like tons of Me Too software, right? And now what that does is when you trickle it down, when you turn it on the front lines, it's a disconnected workflow sometimes. They click here, now click over there to do that, now you do that to do that. And now, okay, now pull all these systems over here together. Now create me an Excel spreadsheet, send it over there. They do things like that. And that's a lot of back end work. And so I think the first thing I'll recommend is that we get a little digital education to the executives and chief operating officers and things like that. Because, and that we opened up earlier, like what is Calix looking at? That's where we're focused this next year. We're focused on peopleware now. We got enough tech. We now got to educate execs on what they have and when to use it. So I want to say it again.
Point. Yeah. Listen, I love when you put people in the middle of things because that's
You
what
have
it's
to.
about. Listen, Dave, finally, tell us, the audience, myself, some trends or innovations you anticipate are really going to shape the future of the health sector. Like what's out there? We obviously talked a lot about AI and ChatGPT. Is that just it, or what are the other trends and innovations? What are you thinking? What's on your short list?
Yeah, this is going to go a little deeper probably than you want on this one. I don't know. I read a little bit too much sometimes. Eric Topol, right? He's a doctor down at Scripps. This guy's a freaking just genius, right? And I follow him a lot, and you guys should too. He posts on various things, and I saw one of his posts on how just like we described what AI is going to do for the workflow, EHR, and all that, right? Well, there's a large group of folks out there that's working on protein folding, modeling, and drug discovery, and all that. The scientists that do these things that create drugs and things like that, they now can say, well, this drug has these kind of side chains, and this is the effects that the effects and the side effects of this drug, right? I think they're going to see a lot more rapid analysis and understanding of drug and makes precision medicine go just that much faster. You're going to see a lot more treatments for cancer popping up out of nowhere because they work now and it's very low targeted treatments. You're going to see imaging, right? The radiologists are worried a bit right now because when you get to do a chest x-ray, that's ones and zeros, right? Okay. So it can pick up nuances that maybe a human eye cannot. They say humans after 15 data points, we're not that good data processors or something. So, well, okay. Now we have the ability for that to augment the radiologist. But the real questions come with, well, what about this? We're in America, with capitalism. What about the financial? What happens there? Well,
Yeah,
we just saw
absolutely.
Google lay off folks. We saw Facebook lay off folks, things like that. So I'm not foolish enough to feel that AI won't disrupt significantly the economics of the US, of the world, right? So I think the win will go to those folks that get through the Kubler-Ross stages of grief, the anger, bargaining, and all that, and get the acceptance. I think the win's gonna have to go to those that can kind of get the acceptance really quick, and then use it to augment, like you said earlier,
Yeah,
augment what
make it
we
work for you. Yeah, and I
make it
think
work for you.
what I heard in there was, some of the modeling, right? The pressure testing, particularly in drug discovery, the whole ideation component, it opens up a world there that is just fantastic.
It
Dr.
does.
Butler, this has been really a great show. Fantastic insights from your perspective, sharing, what you do with Calyx Health Partners, and obviously having your point of view as a physician, internist, both adults and peds. It's great to have you out there advocating and having your voice still be one that represents the folks at the bedside. So thank you for everything you do.
Hey, thank you, Rick. You're a nurse. You're doing it though. So I see you. You're the same. You still remember the smell of betadine. I'm not. Watch that. Anyway,
No,
you look good. Thanks for having me on. I really appreciate it. I really
thank
do.
you.
Thank you.
Great show. Take
All right.
care.
Take care.
The opinions expressed by the host and guests are for informational purposes only and not associated with any companies or academic institutions. Please follow us wherever you listen to your podcasts, as well as our YouTube channel, Healthcare Nation Podcast. And if you have any questions or want to contact us, please reach out to healthcarenationpodcast.com.